So today we're going to talk about pulmonary emboli. Now, there's nothing scarier to most people than hearing about a pulmonary embolism. You know, you hear about these stories of people getting off the plane and dropping dead, uh, and these horror stories. And so it does affect people in terms of their fears, obviously, but not everybody has a pulmonary embolism passes away. In fact, there's a lot of people that we see who've had pulmonary emboli who didn't even know they had one. So it can really vary in terms of severity from just really asymptomatic to significant cardiovascular collapse. So what is a pulmonary embolism? A pulmonary embolism is a blood clot that ends up in the lungs. And so the lungs are really the filtering system out of the heart. So the heart pumps deoxygenated or low oxygen blood out into the lungs, and then the low oxygen blood is converted into high oxygen blood with gas exchange through the lung, and then it comes back to the heart and is pumped out to the rest of the body. But if there's a clot particularly in the lower extremities that breaks off, what it does is, remember, this is all a circuit, right? It goes up and flips through the heart, generally speaking, and ends up in the lungs. And that's what causes a pulmonary embolism. So the symptoms of a pulmonary embolism can be, again, asymptomatic, meaning having no symptoms at all, to significant symptoms. But the typical symptoms that you have from it is what's called pleuritic chest pain. So, pleurisy, the old symptom that we used to call pleurisy, kind of a sharp pain with inspiration. So pleuritic chest pain can be either side depending on where the embolism is, or both sides. And so it's a really kind of a sudden onset of significant or even sometimes milder chest pain. Sometimes you get a cough with it, but then shortness of breath if it becomes significant. And the symptoms can be slow onset. So I've seen people who come in, and say, over the past 2-3 weeks, I'm getting more and more short of breath. And then you kind of evaluate them. Well, they've been embolizing in that time frame, and it's gotten to the point where they really kind of started paying attention to it in a way, and they're getting short of breath. And so those situations are not unusual at all. So when I see somebody with a blood clot in their leg in the office, I always ask them if you had any chest pain or shortness of breath. And if they haven't, then I'm not sure it's worthwhile getting any kind of further diagnostic testing. Like the diagnostic testing of choice for a pulmonary embolism is a CT angiogram of the chest, which is a especially phased contrast injection to look for blood clots in the lungs. And so if they're not symptomatic, I'm not sure it really adds a whole bunch to get a CT angiogram of the chest, because they're going to have their blood thinned out anyway. And that's the treatment for pulmonary embolism, which we'll get to in a little bit. So if they have significant symptoms, then I think it's fair enough to get a CT angiogram and confirm it. But then what would you do at that point? If they're having a little bit of chest pain, a little bit of pleuritic chest pain, some shortness of breath, getting a CT angiogram, which shows a couple of pulmonary emboli, well, if they're not in trouble, then you don't necessarily need to be more aggressive about their management. They just get thinned out. They get their blood thinned out with those medications we talked about, Eliquis or Xarelto, one of those, warfarin, Pradaxa, to prevent more clots from breaking off from the legs and ending up in the lungs. And so what happens, the natural history is once you put people on blood thinning medicine, these things generally speaking resolve. Not always, but generally speaking resolve. Even if they're quite extensive, they can resolve just by themselves. Now, do we get repeat CT angiogram testing at a later date? Not necessarily, unless they're having persistent symptoms. But a lot of the times, patients just kind of resolve their symptoms with time. So what's the other way of diagnosing this? Well, if you have poor kidney function, really can't do a CT angiogram. When we do CT angiograms to look for these things, we give about think about 70 cc's of X-ray dye. And so if your kidney function is poor, one of the complications of X-ray dye is you can tip into kidney failure and go on dialysis. And so in that situation, we're worried about somebody's kidney function, then we'll do a what's called a VQ scan, ventilation perfusion scan, not quite as diagnostically as accurate, and we don't use it very much anymore. We use it occasionally, but CT angiogram is really the way to diagnose it. So let's walk through the scenario. You come in the office, you're having leg swelling, chest pain, shortness of breath. Fine, venous Doppler, confirm the diagnosis of DVT, start you on the medication. Depending on the severity of your symptoms of chest pain and shortness of breath, if you're really in trouble, emergency room, be admitted. I'll kind of go down that pathway. If it's just a mild symptom, CT angiogram, confirm the diagnosis, and then you're still on a blood thinning medicine. What's the point of the blood thinning medicine again? The blood thinning is to prevent more clots developing. It doesn't really dissolve the clots. It develops more developing, then your body says, hey, I got a bruise inside me to get rid of it. It does the same thing with your lungs and your legs. It usually just kind of resolves by itself. So that's the point of the blood thinning medication. At least 6 months of it is my recommendation. And then at that point, we can talk about getting off of it. Now, again, workup for clotting disorders, depending on what my concern is about you having a clotting problem, is probably in order depending, again, if you had recent hip surgery and knee surgery and this happened to you, then it's not surprising that you've developed a blood clot, because that's one of the potential complications of laparoscopic or major orthopedic surgery. But if there's no family history, or excuse me, if there's a family history of it, or it's a spontaneous event for no particular reason, you didn't go on a long car trip or plane ride or something like that, polytrauma, then I may be more inclined to have you see a hematologist to work you up for a clotting disorder, because there is more and more clotting disorders being discovered, and so we may keep you on blood thinning medicine long term. I'll kind of get into that when I talk about chronic DVTs and anticoagulation management, which would be a separate video. But so you come in, you look pretty comfortable. Blood thinning medicine usually resolves with time. In terms of physical activity, I always counsel people, look, take it easy. Don't overexert yourself. But the days of hospitalization and heparin, blood thinning, and all that stuff is kind of past. So what happens if I'm really worried about things, or if you end up in the hospital emergency room just in and of itself? You're at home, you collapse, or there's significant shortness of breath. You're taken to the emergency room by EMS. You're evaluated PE and severe shortness of breath. Well, at that point, there's another algorithm that we think about, like, how bad is this person off? Are they young? Are they old? Can they tolerate blood thinning medicine? Can they tolerate more aggressive approaches? Do they need more aggressive approaches to management? So nowadays, a lot of facilities have what's called a PERT team, which is a team of specialists that evaluate whether you should go through a more aggressive treatment to manage this. And it's really depending on your symptoms, how short of breath you are, your oxygen level, your leaking of heart enzymes into your bloodstream, so-called troponins, CKMB, troponin level, and perhaps an echo of your heart to see if that's what's called strain on your heart, your right side of your heart, which is the side that pumps out towards your lungs. If it's under a lot of strain, you can see it on echo. Then there's some measurements you can make based on the echo that suggest that you've got developing what's called pulmonary hypertension. The right side of the lung is having a tough time pumping out because of the clots that are ended up in the lung. It's having a tough time pumping against those clots, and so it can get into trouble, get into acute right heart failure, and that's really kind of a problem. So if it's deemed by the PERT team that you're a good candidate for aggressive approaches, then you kind of head down that pathway. Now, the PERT team really, it would be best, but it's not always this way. It would be best if a PERT team was a multi-specialty team, meaning that there's multiple inputs: the ER physician, the critical care physician, the interventionalist, whether it's an interventional radiologist, cardiologist, or vascular surgeon, kind of get together and individualize a decision for each person. because then you have different people putting inputs in about what's the best way to manage a situation. So you don't have overly aggressive management because, if the whole world, I'll say this a lot, if the whole world looks like a nail and your only tool is a hammer, you're going to hammer that nail. So you need a multi-specialty input, but sometimes we don't have that. So we have to settle for the interventionalist who can make that decision. I think most people are not super aggressive about this. They kind of think through things, and there's certain indicators. So if you meet those indicators, you look like you'll do better with what's called pulmonary thrombolysis, then you're taken to the X-ray suite, and there's guidelines for all this stuff, by the way. You can be given peripheral TPA, which is a blood clot busting medicine, 100 milligrams IV in the emergency room, again, depending on your clinical condition, or you can be taken more likely nowadays to the cath lab, where through catheters that are placed in through one of your veins into the lung circulation. So it essentially goes up through the heart and flips out into the lung circulation, where you can diagnose these clots, and then you can do what's called catheter-directed thrombolysis, where you inject medication through those catheters to bust up those clots. Either way, you're going to end up in blood thinning. And so the advantages of the more aggressive approach is you get rid of the clots quicker, and so your right heart pressures go down quicker, and your recovery is quicker. The downside is you're using blood thinning medicine plus blood clot dissolving medicine, so you have a higher risk for having a bleeding episode. But again, that's where that whole issue of having a PERT team that manages the risk versus benefits of any kind of intervention makes sense. Years ago, all we had was a blood thinning, and people who were critical often didn't make it. But nowadays, with these more aggressive approaches, we can salvage people who otherwise years ago would not have kind of made it past that point. So that's, in a nutshell, management of pulmonary embolism. Standard treatment is just blood thinning. Most people, that's all they need. But if you're in trouble and the team says, you know what, this person is probably going to be better with a more aggressive approach, that's the pulmonary thrombolysis. It works very nicely. The complication rates are low, but still, it's an invasive procedure, and so the risk-benefit analysis is always important. So I'm going to wrap up veins with a brief discussion of chronic DVT, which is different from acute DVT, totally different. So I'll talk about that, and then we'll progress on to arterial things like aneurysms, carotid artery disease, and discussions about that. Again, feel free to ask questions, type them in the comment section below, and I'll try and give you good generalized guidance about these issues that you may or may not be facing. Thank you.